Yeah. Good morning, everyone, and thanks for joining us this morning. Let's move straight to business. Thanks, Mr. Yemi, for um, taking us through how to use the program. So this morning we're just going to do a bit of small teaching to get everybody into the mood of the new cohort. So, as for the guys coming back, welcome back, and for the new guys joining us, welcome to you as well. So each cohort usually runs for a period of 2.5 months, and this cohort comprises of various groups, as the introducer has clearly um, said. So for your own group, please take note of what you'll be doing. Joining a different group may not be very beneficial to you. Today, we've just put together something that could be beneficial to everybody. We have various teaching styles at EasyLearn. One of our teaching styles is to use the picture system. For the last orientation, for guys who joined us, we did do the topic system where we looked at cardiology and some high yield topics. So today we are using the picture system for our orientation. And we've decided not to use one topic area. So we're going to do what we call mixed teaching today. My full name is Olale Kongunbemi. I'm a GP, salaried GP, and a portfolio GP. Salary GP in Dumfries in Scotland, portfolio GP with special interest in public health and in education. Um, I'm also a scholar at Oxford University at the moment. Right, okay, so let's make it a bit interactive. That's what this session is for. So I'm just going to put some questions in front of you. Please, if you can type into the chat box so that you can participate. Don't worry about the answer you give. It's all a learning process. It'll be nice to see what you guys think about this. So, ethical principles. Let's see our first question. Which of the following ethical principles explain equity? If you think the answer is A, put beneficence in the chat box. If you think it's B, non-maleficent, C, justice, D, autonomy. And if you think none of the answers are correct, put none of the above. You have about a minute to choose your answer. Right. So, um, quite a lot of you have chosen various answers. I saw people choose C, such people choose A, B. Yeah. So, let's see what this answer is. So, this picture, so the question was about equity. This picture shows you something. So, you can see the first boy. He's trying to see what's happening across the fence, over the fence, but he was too short. So what happened is he did climb something to put him up. But you can see his friend, he's just that's he's not able to climb anything. And you can see the other guy is climbing something very tall, and he's the tallest. In reality, on the NHS, this is what happens, or in some healthcare systems, this is what happens. Certain people have the ability to get things faster for various reasons. So the first picture shows what does really happen. The tallest people are on a platform that even makes them taller, and the shortest people have no support at all. And this is a show of how different countries are. So it's not just about the UK. The poor people in some countries do stress and suffer to get the needed health amenities. And that's the economic reality. So the first picture there is reality. Now, if you see the second picture, that is equality. And this is what the question was asking. Which of the following ethical principle explains equity? So most people chose C, D. Very few people chose E. You need to know the difference between the second and the third picture, which is the whole aim of this picture: equality and equity. So, as you've seen, equality and equity are not the same. All of them have been put on the same level platform. However, because one person is still taller than the other one person can still not see what's going on in the stadium, you see. So, equality has to do with giving everybody the same level playing ground. It doesn't mean raising everybody to the same height by trying to make everybody be on the same at the same point. So at the end of the day, what equality does for you is to give you the same thing as every other person, being fair. It does not make sure that you are on the same level as other people. Now, what's today's question asking about? Equity. Equity. So, equity is making sure everybody is at the same level. So, the first person, let's assume the first person is a rich man, second person is a middle class, and the third person is a poor man. What equity will tend to do is to tax the rich more, make sure that the taxes on the middle class is not too much, and don't tax the poor at all, trying to make sure that they are all on the same level. In reality, this is almost impossible, very difficult. But that's what the question was asking about: equity. And the last one is liberation. Now there's no fence, they can come in. I mean, liberation in the world, you have to do it yourself. Nobody liberates anybody. If anybody is promising a society liberation, probably won't work well. So this picture has been put there to help you understand what the question is about. So if you did choose none of the above, I think you're correct. So why are you correct? Because these are the ethical principles. Beneficence, I think most of you know what these things are. Acting in a way to benefit the patient. Non-maleficence, try to do no harm. Justice is equality, not equity. You see, so if you have chosen justice and you are not very happy you failed the question, this is why you failed the question. It is equality, not equity and fairness. So if you do see that in any of your exams, I do know that there are people who are writing the QA1 here, people who are writing the AKT, some people have just passed their AKT and are planning for the SCAs, and I know there are ST1s here. So that is what you need to know. The NHS is built on one of the principles called justice, which is equality and fairness, not equity and fairness. The other thing is right to make your own decision. So you need to support everybody to be able to make their own decision, and you need to be able to give them that opportunity to make their own decision, what we call informed consent. So tell them what it is about and do not interfere in their decision making process. So if you do see this in one of your exams, you should be able to maneuver this very nicely. Right. I'll give time for questions. We can do that maybe at the end. So if you write, or if you feel you forget, you could ask questions as we go. Um, let's look at another one. Abortion, common question that comes out for the guys writing the AKT in admin. So regarding the Abortion Act of 1990, that's for the United Kingdom, which of the following is correct? So again, get into the chat session and put the correct answer or put the answer you think may be correct or is correct. So A, two registered medical practitioner must justify a pregnancy not more than 22 weeks. B, only a doctor can terminate a pregnancy and it must be free of charge. C, after termination, the HSA form must be submitted to the chief medical officer within 12 days. D, injury to mother's physical and mental health is not an indication. And E, abortion due to undesired sex of a child was legalized in February 2024. So, which of them is correct? Great. Many of you have put your answers. Please don't feel sad if you failed question one and two. It's all the learning, it's all about the learning process here. And before you know it, you'll be quite good because you would have covered quite a lot of stuff. And this is one of the good things about what we call mixed teaching. So I am one of the advocates that when you study, please do a little here, a little there. What that simply means is do a few questions in cardiology or look through a few topics in cardiology. And on the same day, check neurology. On the same day, look into statistics. On that same day, learn something about admin. You see, it's always good to be a bit balanced, learning things in small bits around across subject areas rather than staying on one subject area and being a master of that subject area. It doesn't everybody know good. So let's see which of these is correct. Well, when it comes to abortion, there are a few things that we need to know. So the Abortion Act in 1990 says that two registered medical practitioners must justify a pregnancy which is not more than 24 weeks. The age of abortion in the UK still remains 24 weeks. So if you chose A, the answer is wrong because it stops at 22 weeks. There are people within a 2 weeks gap that you have cut off. And so that's why option A was wrong. Well, let's go on to see what B says. Only NHS hospitals or places approved by the Secretary of State can be used. So there are certain places that are approved. So it's not just NHS hospitals. There are certain private hospitals that can that are approved for abortion. And those hospitals have been validated or approved by the Secretary of State. Only a doctor can terminate, and it must be free of charge. I think that was our option B there. Only a doctor can terminate, and it must be free of charge. Well, if your answer was B, it's correct. But let's see why the others are not correct. So the option C says after termination, the HSA form must be submitted to the chief medical officer within 12 days. Let's see if we have something that makes that wrong. Okay, so the HSA forms are used for justification and are kept in notes for 3 years. So after 3 years, they can be destroyed. HSA 1 is the usual form, while HSA 2 is what we call an emergency abortion form for people in Scotland. After examination, the forms must be submitted to the chief medical officer within 14 days. So the number there made that wrong. Sometimes in your exam, just very small things have made the option wrong. So that option was wrong because it says 12 days. Some of you thought you had this because you've seen this, but the numbers were wrong. And this is what we do at EasyLearn. We try to show you loopholes. Certain people learn broadly, but they do not learn fine details. So please know that 14 days is the period of time and it's important. So otherwise, if this is not done, then it becomes a criminal offense. Let's see if we have more. Yes, so abortion, legal indication, so risk to mother's life. That question said, let's see what it said. So if we go back to option D, injury to mother's physical and mental health is not an indication. It's definitely from what we've seen an indication. And abortion due to undesired sex of a child was legalized in February 2024. There is nothing like that. So in February 2024, nothing was said about abortion. The Abortion Act was not amended. So abortion due to undesired sex of a child is a criminal offense, by the way. So people can land themselves in 6 months in prison with an option of a fine. You can see injury to mother's physical and mental health is on the indication list. Okay, so if you've got that, kudos, well done. If you've not got that, you now know the correct answer and you know much more about abortion. On the program, when we go to admin, we're going to talk a bit more about abortion. So we're going to see other things we need to know about abortion. Right? Adoption, you see, when you talk about abortion and you've not talked about adoption, then you've not talked about administrative part of general practice. So everybody needs to know something about adoption. Let's see this question. The average time required to complete an adoption, so that's adoption, an adoption process is A, 3 months, B, 10 weeks, C, 4 years, D, 6 months, and E, 18 years. Let's see what you think about this one. Right, okay. So I've seen a lot of answers. I think most of the answers are between C, D. Someone chose A. Well, I think majority of people got the answer. This one was probably a giveaway, and you see some of these kind of questions in your exam. So 6 months. I mean, when I say giveaway, it's not people that have no clue about adoption will be able to do what we call an educated guess. An educated guess means trying to use common sense to rule out. 18 years is definitely too long for an adoption process. I think everybody will agree with me. So E is definitely wrong. 4 years is definitely too long as well. So the answer will be between A, B, and D. Well, it may pose a bit of a challenge, but the answer is 6 months. But these numbers here, so the answer is D. But these numbers here, they definitely mean something. So rather than just focusing on what the answer is, let's learn something new today for people who don't know much about adoption. So this is the adoption um, numbers. We have a video on our YouTube page that explains a bit more about adoption. Please, everybody should know everything about adoption. So, in terms of adoption, the child must have lived with you for 3 months. In some places, they'll say 10 weeks. We've put the two there in case you're seeing that in your exams. You don't get confused if you see weeks, 10 weeks, or if you see month, 3 months. They are both correct. Okay? Minimum age of adopted child. You cannot adopt a child that is 2 years. It's against the law, not even 1 year. So the minimum age of adoption in the UK, 4 years. Minimum age to see birth or adoption certificate. This is a child that says, well, I want to know if I was adopted and I want to see my birth certificate or I want to see my adoption certificate. You can only disclose this to them at 18 years. You see, 18 years. Be clear about that. Minimum age required by law before adoption can be allowed. You see, you want to adopt someone, you are 19, the law says you cannot adopt. You are 15, the law says you cannot adopt. You are 20, you're going to be 21 in 2 months. You still cannot adopt. You see, you need to be 21 before you can put in an adoption filing or process. Average time required to complete the process, which was the question, is 6 months. 6 months. So when it comes to admin, they can ask many questions in the exam, and or even in the practice. You can be sitting in the practice and someone comes and says, please, I want to adopt. It's good to have good knowledge. And we're going to be talking about this in depth on the program. Another question you can see in your exams or in the practice, it can become something to talk about, is which of the following is a justifiable ground for patient removal from the surgery? You see, so someone says, oh, because I don't really like the patient has missed a couple of appointments, the patient is complaining about me. These are not reasons to remove a patient from your practice list. So these are some of the things that we'll be looking at when it comes to admin and a bit more. For admin to be clear, before you go for exams like the AKT, you need at least 250 points. So this is a point. Adoption is a point. Abortion one is a point. So let me show you what abortion one will be. So this is abortion two, for example. And if you go here, this is abortion one. So there's abortion one, two, three. We don't want to crowd the screen and stress anybody today. We're just taking it very slow. But this is 1 point. This is another point. This is abortion two. There will be another one called abortion three. The same thing. This is going to be adoption 1 point, and there's adoption two. So you need a minimum of at least 200 points, and you can say, yes, I'm quite good. Anything when it comes to administration, yeah, I should be ready to answer any question about any administrative topic in the practice and in the exams. I'm talking about someone coming to inquire about maternity. I mean, you should be very clear. Yesterday on the group, I saw one of the questions, which was about the FP27A and all the FP. Those are the free prescription forms. There are about 5 of them. You need to know who qualifies for free prescriptions. So one of them was about which of the following conditions, so free prescription by condition, which of the following condition does not qualify for free prescription. You need to be clear. So that answer there yesterday was psoriasis, but there are other conditions that do qualify. So it's better to know the ones that qualify, and then you can easily eliminate the ones that do not qualify. So things like medications that need to be prescribed by brand, Camlight, which we teach on the program, medications that are known to cause seizures, mama back, things about fit notes. They are very common admin questions. I mean, the questions are a lot of them, but they are very simple. One of the easiest ones would be fitness to fly, fitness to drive. Fitness to fly has fitness to fly cardiology, fitness to fly neurology, fitness to fly psychiatry, and the same thing with fitness to drive like that. They have subtopics. These are all the things we'll teach you. We'll teach you very, very simple. We'll give you things to help you, what we call remembrance aids for people who like mnemonics as well. You're going to have mnemonics that will help you for things you do not easily absorb. So basically, this is how your admin questions will come in your exams and in the day-to-day practice for ST1s. And this is what we would want you to know. Now, let's talk about Cynthia. Cynthia is a 35-year-old female, as you can see, and Cynthia has basically presented to you with disabling nausea. She's been vomiting. In the last 3 days, she's had ataxia. So she's not very happy. You can see her. She's distressed. Prior to all this happening, Cynthia tells you, doctor, I had an upper respiratory tract infection, what we call flu-like symptoms. Now, can anybody guess what the diagnosis is likely to be if Cynthia says she is struggling with her hearing? She says, well, you asked her about hearing. She says she's not struggling with hearing, but she says, well, I'm falling towards one side, doctor, and I'm having this nausea, vomiting, but my hearing is okay. If you type the answer in the chat box, there's no option this time. Let's see if you can fill in the box. That's one of the kind of questions you may see in some exam. That's one of the exam patterns. So if you think you know what's happening to Cynthia, please type the answer in the chat box. Excellent. Quite a lot of you got the answer. Vestibular neuronitis or vestibular neuritis, quite common. So that's what Cynthia is suffering from. It's quite sad. It causes this nausea and vomiting and vertigo. So she may just say, "Doctor, I'm unable to stand. I'm unable to do much." And this does put a toll on patients' life. We've already what we've done for guys on EasyLearn is we've got the nice guidelines document for at least 100 topics, super high yield. We have simplified the nice guidelines to make it look like you are taking ice cream. It's so simple. It's broken down into what the doctor should know and what the doctor should be able to do for the patient, what the specialist will do for the patient. When I say the doctor, I mean the GP, what the specialist will do for the patient, and self-help tips alongside a few things. They are all 1 page each or half a page. So it's just a summary of the nice guidelines as updated by July 30th of this year. So July 30, 2024. You have for all the high yield topics. And one of them is vestibular neuronitis or neuritis. So this is going to be a patient that is in a lot of distress. She may complain of ataxia. Now, take note of what the question will say in your exam. It's toward the affected side. So, if the side is the left ear, for example, she may sway or fall towards the left side. Same thing if it's on the right side. Remember, if it's labyrinthitis, it's usually only one ear that is affected, not two ears. Yes, so nystagmus again towards the affected ear initially, and it can change towards it going chronic. And the treatment will be to use anti-vertiginous medication. So when we talk about anti-vertiginous medication, please note that you need to be careful. Is it mild? Is it moderate? Is it severe? Well, if it's mild to moderate, please try cyclizine or your promethazine, but your first line will be oral prochlorperazine. You can try cinarizine if you don't see oral prochlorperazine in your options or in the practice. You can use cyclizine. You can use promethazine. However, NICE is clear. Oral prochlorperazine may be preferred to all other options. This is not the same case when it becomes severe. Severe is a patient that cannot do anything. Severe is a patient that is vomiting almost 4 or 5 times a day. Severe is a patient that has landed herself in A&E. So if it's severe, please, this patient cannot keep anything down. As you can see, she'll be vomiting. So if you give her oral prochlorperazine, what happens? She's going to come back and say, I'm worse. Why is she worse? The medication has not been absorbed into her system. So the answer there will be buccal prochlorperazine if you still want to give something that is not IM. Otherwise, intramuscular prochlorperazine or cyclizine will be your answer. Is there a role for bed rest? Yes, this patient should be advised to rest adequately, hydrate adequately, and in some instance, the specialist may decide to give methylpred. It's not a very common practice, but in case you do see someone in hospital doing that, and it's not out of place. Now, what do we do on EasyLearn? This is not a program just to teach you for your exams. It's a program to make sure that you are all round a good GP. You turn out to be the best GP around. And so we tell you everything you need to know. So that's vestibular neuritis. Now let's talk about John. Well, John is holding his head. I believe some of you think there's a problem with his head. And there is actually. John has same side every time, redness of the eyes, which is on the left. He's always tearing. He's complaining about what we call a short-lived headache. The headache is usually less than 3 hours. He's very restless. As you can see him, anytime this headache starts, he cannot do anything. John is miserable. Well, the question here is, what's the diagnosis? Tearing, red eyes all on the left side, short lasting headaches, which is always on the left side. So, and the other question will be, how do we treat John? What do we do to manage John? So again, if you come on your chat box, how do we treat John and what's the diagnosis? Okay, so cluster headaches, someone or a group of people have put the correct answer. And I saw a lot of 100% oxygen. Now you need to be careful. How easy is it to get 100% oxygen in your practice to give John? Remember, you are a GP. You are not an emergency medicine physician. You are not an internal medicine practitioner. You are a GP. So what's easiest for you in the community? Is it 100% oxygen or is there another option? Anyway, let's see. So John is seated in front of you. He's told you his ordeal. He's telling you that same side every time. That's where he gets the headache. It's ipsilateral tearing, redness of the eyes, which is very distressing to him. He says it's very severe when it comes on and is very frequent. So frequent is happening in clusters. Well, John says it doesn't last more than 3 hours. Whenever it comes, it's short-lived. But at those periods of time, I'm restless, doctor. I'm miserable. I can't do much. Doctor, help me. Well, this is how I think you should help this patient by proposing he can have nasal zolmitriptan or he can even have somatriptan. I think that will be an easier accessible medication in the practice if you can get that. So the somatriptan can be given by the nurse. It's subcut, not IM. Don't fail the question. And the zomotriptan can be given as nasal. See, so nasal can work. However, those who put high flow oxygen as treatment, you are correct. Please always put yourself in the shoes of a GP, not the shoes of the posting you are doing in hospital. Otherwise, in the AKT, you may get very confused. So that is the answer. Congratulations, all of you who got the answer correctly. For you who have not got the answer correctly, again, congratulations because you now know the answer. Right. What does the specialist, what's his role in management? Please, for every new diagnosis, the NICE guideline, at least up until today, is very clear. New diagnosis sent to the neurologist. The specialist should be seeing the patient. Again, for patients who have not done very well on oxygen or somatriptan, again, the specialist should be seeing the patient if you are sure that the diagnosis is cluster headache. So specialists advise again for a verapamil, which can be used. So prophylactic verapamil is the prophylaxis of choice. Before starting it in practice, please speak to the specialist as well. So these are the areas where the specialist gets involved. We say cluster headache, the most important things are the 5 S's. One of the S is the management. One of the S is this when to see a specialist, and the other S is how we present. Okay. So that's cluster headache. Let's do our next patient. Well, some people have already said the answer. This is Michael. And you see, this is what picture does for you. Speaks more than 1,000 words. See? So some of you have seen this, you've said the answer. And this is how we want it to be in the exam. You are reading something, but you are creating an image of Michael in your head. Is a picture. Even write-up can be converted to picture in milliseconds in your brain. And this helps you to answer questions in less than 5 seconds when you can create a proper picture of what the question is saying. The time question, when they struggle to create a picture, that's when they start to have problems. So it's always good to create a picture in your head. Right. So without a question, I know some of you have answered it, but I'll tell you the question. Michael is 41-year-old, got inability to wrinkle his forehead on the affected side. This is he used to be better than what you're seeing on the screen. He's got associated post-auricular pain. Again, he's got some rashes, vesicles, which we can't see now. He had them. It's clearing up. It was very painful when they came. Mouth is deviated, as you can see. He has started complaining about eye dryness, and his taste is altered. Right. So if you know the diagnosis, please don't just tell me the diagnosis, tell me the treatment if you know both of them. Thank you. Okay. Seeing Ramsey Hunt, Bell's palsy, and all that. Yeah. Okay. So this guy has what we call post-hepatic Bell's palsy. So if you chose Bell's palsy, great answer. Now let's look at Bell's palsy in detail. So we've talked about him inability to wrinkle forehead on the affected side. Talked about associated post-auricular pain. We've talked about that. Okay, we've not talked about this. So everybody does agree, and that's why it's on the NICE guidelines. Prednisolone is going to be the answer. So please be careful with a cyclovir. A cyclovir, prednisolone plus a cyclovir, it should be specialist advice. Prednisolone is what you should be doing. Only prednisolone, please. So consensus treatment is with prednisolone. In the past, a cyclovir used to be a must alongside prednisolone, but it's changed now. Now, excruciating vesicular lesions. Remember, when the patient is having um, Bell's palsy, they can have, if it's affecting the ear, so some people have put Ramsay Hunt's. Remember, there's the oticus and ophthalmicus as well. But we're going to talk about all those things when we are on the program fully in details. So mild deviation, which you can see, eye dryness, lower motor neuron lesion, and altered taste are all symptoms this patient will present with. So just to remember a good number of important things, remember the face of a melting face. So if you see a melting face, then think, could this be Bell's palsy? Try some of the things that will be written on the screen, like can they wrinkle their foreheads and all that. And if they can, or if they can't, that will help you with your diagnosis. So this is a lower motor neuron lesion. Please, prednisolone within 72 hours. Do not forget eye care. So eye care is to prevent what we call keratopathy, please. Keratopathy. And when we talk about eye care, please, what do we mean? They could wear eye patches or you could tape the eyes. Remember that some of them will need, or all of them should have artificial tears if you can. Anyone will be good. And then follow up. Now, follow up is a question in your exam. Follow up in greater than 3 weeks will be ENT. So usually tell them this should improve within 3 weeks. In 3 weeks, you should be better. This patient has come back to you. That's Michael. He says, Doctor, I am not better. Can you do something? I'm getting frustrated now. In fact, I've taken a month sick off. What do I do? So what you should do is basically after 3 weeks, ENT referral. Well, after 5 months, ENT has tried a few maneuvers, tried a few things. It's not getting better. It probably means this is permanent. If it's after close to 3 months, 4 months, it's not getting better, then it's probably that this patient will need plastic surgeons to readjust his face because it won't improve any further. So a quick way to remember is the rule of three: greater than 3 weeks ENT, greater than 3 months plastic. All right, so that's post-hepatic Bell's palsy or Bell's palsy. You should know everything about Bell's palsy. We do passionately teach topics like Bell's palsy on the program again and again. We do believe that repetition is the way to remember. And so things like face melt will help you, but we'll give you a bit more so that you can understand how to navigate these things in your practice, which is the most important thing. Remember, some people are concerned about exams, but remember that it goes beyond exams, and even the exams are there to help you to be good GP. So it's all about being a good and safe GP. Right, that's Chris. And although he's smiling, Chris has had a very rough time, you see. Chris is presenting with incontinence, dementia, and of recent, he's been falling, ataxia. So if you think you know what's happening to Chris, incontinence, his new onset dementia, and is ataxic. If you write the answer, the diagnosis, that would be nice. You guys are very smart. I think everybody got that diagnosis. Ayaka, I can see your hands have been up for a while, and you can just ask your question now. But for other people, if you just wait till the end, we can have a chat. Ayaka, please go ahead. If it was a mistake, that's fine. Ayaka? Okay. So if you chose normal pressure hydrocephalus, you are super smart. You will not fail that. Yes, Ayaka?
Yeah,
You want to say?
sorry, that was a mistake. Thank you.
Okay, that's fine. So if you chose normal pressure hydrocephalus, you won't fail that in the exam. There's no way that you will not see, you may see a bit more symptoms, but you must see what we call IDA. You see? This is how easy learn candidates smash the exam. When they get into the question, they are looking for what? IDA. They read 83-year-old is likely to be an elderly man. You see, 83-year-old has been having incontinence for months. That incontinence triggers a lot of things. Is this shy draggers? Is this some sort of Parkinson's associated syndrome, which there are a couple of them? Is this normal pressure hydrocephalus? That candidate has become sensitized as he sees incontinence. He's become ready to check for dementia. How would they write dementia in your question? Gradual memory loss. If you're looking for dementia, my friends, you will not see it. Trust me. So you would see that his wife has been worried about gradual memory loss, or they may say that he has been wandering around. What's that? Alzheimer's. You can't fail it in the exam. Now, if you are looking for the word ataxia, I can bet you can come back to me, collect £100 for me, I will give it to you. You won't see it. They'll write it in a different way because the exams that you're going for, either the QE1 exams or the AKT exam, they are applied. You see, applied knowledge test. So if they give you 82-year-old Chris has presented with incontinence, dementia, and ataxia, that's no longer applied. They haven't stressed you, you see? So you need to be prepared for their devices. Their devices is how they apply it. And this is what we do in the question sessions. So we have days where all we do is sorting out questions, and solving the questions is not about cramming it. Solving the question is not only about knowing it, Solving the question is about being in the head of the examiner. Imagine you've solved at least 5,000 questions before the exam. You will be in the head of the examiner. As they are reading the first line, you are laughing because you know where the examiner is going, and you will never be wrong. This is a skill. What EasyLearn has done is we've taken 2 years to try and study how do people set questions in the UK for things like AKT. We've further gone to the MRCGP, we've gone to their website, we've looked at how their patterns are. And this is how we can tell you what to expect, and you won't be wrong. You see that exactly what we spoke about or the type of things we are doing are the type of things you see in your exam. But beyond that, what do the patients, your patients in the United Kingdom, what would they say to you? You see, these are some of the things that reflect in your exams. So either is what you should be looking out for. Incontinence, dementia, ataxia is normal pressure hydrocephalus anytime, any day. If they wake you up, just shout Ida, you will never be wrong. So well done. Kudos to all of you who got normal pressure hydrocephalus. For you who are not very sure of the diagnosis or who have never heard about this condition or who have not seen it in a while, please keep things simple. Learn Ida. Right, let's see. This is Ran. Well, some of you already know what's happening to Ryan. So some of you are already writing the answer in the chat box. That's very good. This is the power of pictures, you see. But this is also the best way to learn, because the next time you see it will be in the exam and they will be describing this picture. They will say he can dorsiflex or plantar flex his left hand, but his right hand, he can't do the same. You remember this picture because pictures speak louder than words, right? So this patient has been complaining of in the hand. So there's a hand with a cannula, depending on how you're looking at it. That hand with the cannula is meant to be the right hand, and the other is the left. So, but the hand that doesn't have the cannula has a problem, right? So he's been complaining of some stabbing pain. This patient is a chronic alcoholic. This problem started on Saturday, and today is Monday. So almost 3 days now. In the past, he has been asked whether he uses crutches, and he said no. His elbow, he's been asked whether he's had elbow or other bone injuries, fractures. He's been examined. Nothing else was found. It's just that he's an alcoholic. He woke up, he found this. Well, let's give you some time to figure out what the answer is. Please type in the chat box what you think the answer is. Great job. Okay. So again, most of you got the answer correct there. So that is radial nerve palsy or radial nerve injury. So that's Ryan, and Ryan has found himself to have this condition, or he put himself in the condition. Someone would say how. But let's look at what SECA ward is, because that's the word he was admitted to. He was admitted to the SECA ward. Right. So that's the meaning of SECA ward. So sometimes it may come with stabbing pains, and one of the sometimes it may come as a result of stabbing, not stabbing pains. If the radial nerve has been punctured or has been stabbed, then this patient may have that injury. It may come as a result of sitting position. The patient that has been sitting on their rocking chair and they are compressing the radial nerve. It may come as a result of sleeping position as well. So any position that does compromise the radial nerve can cause a radial nerve palsy. Right. Injuries to the elbow, the humerus from humeral fracture. Remember that this nerve basically twines around the humerus, around the neck. So if there's an injury there, well, what do you expect? A radial nerve palsy. People that use crutches, they may be compressing this nerve at the level of the axilla. So you can't feel that. So Saturday night palsy is I think everybody knows that, but for people who've never heard about it, is the best way to explain the alcohol night sleep. Is a patient that has gone out drunk, like Ran, and he has slept in an awkward position because he's drunk and he's compressed his radial nerve at some point. So, what are the kind of things that this patient will present with? Wrist and finger drop, which we did not mention so that you do not have the answer very easily, but most of you figured it out. Anatomical snuff box numbness. There may be reduced coordination. As you can see, he can't even do much because of his wrist drop. Now, this is a question that they now ask, and most people they know the rest, but they don't know the deep part. The dorsum from the thumb, the dorsal part of the hand, at least 3.5 fingers can be affected because the radial nerve covers that area. So please note is the dorsal part, and 3.5 fingers from the left from where the thumb is. So dorsal part, right? Okay, so that's a patient that has noticed loss of sensation over his dorsum of the first finger and the web space after taking alcohol on Saturday night. Excellent. Let's see the next scenario. Oh, that's Nancy. Poor Nancy. She's made tea. This is sometime in the morning. She's made tea, but she's very sleepy. You can see. And so what Nancy does is she's trying to pour it into the cup, but she pours it, succeeds in pouring it on her kitchen or her dining table. So let's get the question. Nancy, she's a 39-year-old female. She's unable to regulate her sleep and wake pattern. She sleeps excessively in the day. Her BMI is 22.5, and her doctors explain that it is a brain condition caused by lack of chemicals called hypocretin or orexin, which helps her regulate her sleep and wake cycle. She's looking for treatment. So please tell her the treatment. Of course, before you can tell her the treatment, you need to know the diagnosis. So if you know the diagnosis, put up the diagnosis and tell us the treatment. 1 minute for that. This was probably a bit difficult for some of you. So a lot of people are like, is it this? Is it that? Well, somebody's checking Google to see what's orexin and what's hypocretin. Right? We'll tell you what it is. So a few people got the answer. I saw about 2 or 3 people have put up narcolepsy. Now it's a rare condition. It does come out in your exam, and this is why you have to be prepared. Well, is a diagnosis, rare diagnosis, so it's a diagnosis not to miss. In fact, this diagnosis is underdiagnosed because doctors have missed the diagnosis. So, in the UK, the latest report in 2021 from the Sleep Association says that at least 40% of people with this condition are not diagnosed. And who misses the diagnosis? GPs, you see? So, now, after today, you shouldn't miss the diagnosis. But we're just this patient, she wants to know treatment. How do I get better? Please tell her there is no cure. So if that's the option in your exam, no cure, that will be the correct option. Tell her there is no cure. However, there are things we can do. There are other treatment options that are supportive. So that's narcolepsy. Tell her about strict bedtime routine. That means sleep at 9 o'clock and wake up at 6 o'clock. You see, 9 p.m., 6 a.m. is what we call a strict bedtime routine, or 10, 5, whatever she wants. It should be at about the same time. That does help them. It doesn't treat the condition. That's why there is no cure for Nancy. Okay, tell her about sleep hygiene. Please, if you do not know the sleep hygiene, if you have some time today, just go through it. If you know it but you've forgotten, it's always good to tell your patients in the practice about sleep hygiene. First line management for all sleep problems insomnia, sleep hygiene. So don't forget, if you see a patient struggling with sleep, any sleep problem, sleep hygiene. Okay. Schedule spaced out brief naps. This is going to be in the afternoon. You see, if you tell them not to sleep or if you tell them just strict bedtime routine, they will still sleep in the daytime, which does mean that what we can do for them is to tell them that you need to sleep in the daytime. However, space it out. So during your break, when is your break time? She says, well, my break time is 12:30 to 1:30. Why don't you sleep 30 minutes out of that break time? She said, okay. Any other breaks? Yes, I've got one at 4 o'clock. Okay, why don't you sleep at that time as well? Any other breaks? Oh, I forgot I have a 15 minutes break at 10 a.m. Why don't you sleep during that time? This is what we call scheduled, spaced out, brief naps. She sets an alarm clock and that helps her. She needs to stop driving. So for every sleep condition that will cause you to sleep in the daytime somnolence, that's what we call it. Please, they need to stop driving until they are well controlled. So that's the fourth S. The fifth S is some people would think, oh, if I sleep very well at night, I won't sleep in the day. So why don't I take a sedating medication to ensure that my night sleep is excellent? Well, that is counterproductive. Research has found that that is not helpful. Tell them to avoid sedating medications, but they can use medications that keep them awake in the daytime. So they need a sleep schedule, um, and that can be planned between you and the patient, that's the GP, or you can send them to the sleep clinic, and that will all be done. Why do you need to know this if the sleep clinic can sort out this patient? First of all, you need to be able to diagnose the patient. Second of all, even if you are referring to the sleep clinic, they will ask you, what can I expect from the sleep clinic? And this is why the MRCGP brings out this kind of questions in your AKT. Right. Okay. So that's narcolepsy. Well done for everybody who spotted the correct answer. Nancy had narcolepsy. Hypertension in pregnancy, well, very common, um, especially for those who are in gynae posting. You may have seen this. This is Liz. Liz is not very happy because she has been started on a medication, and this medication has caused her rash. You can see the rash on her face. So the question, which of the following medication is responsible for her looks? Elizabeth is not happy. She's come back to you, say, doctor, what is the meaning of this? You told me I have hypertension. You've given me this medication. Look at my face. Please do something. What's the cause? Please type in the chat box 1 minute for you to do that. Excellent. So some of you chose the correct answer. Some of you did not, but that's fine. That's why we're here. Unfortunately, Liz has developed what we call drug-induced lupus. So you can see this is why exams are applied. First of all, the first step is knowing what is the cause of the rash on Liz's face. So that's butterfly rash, or what people call a mala rash. And a butterfly rash or a mala rash can be caused by SLE or a medication. In this case, the question has clearly told you it came due to a medication. So the next question is, what medications cause drug-induced lupus? You can see the steps that have to run in your head for you to get the answer. But you have 5 to 10 seconds to figure this out. You've not got too much time in these exams. They just want people who are very good. And this is what EasyLearn stands for. So, which of these medication causes drug-induced lupus? If you've chosen hydralazine, you were correct. Brand name apresoline. Hydralazine is not a very commonly used medication again, especially in general practice. However, the RCGP wants to test you to know whether you know when it can be used, when it should be used, and you know a bit about it. So don't be surprised if you see this kind of questions in your exam. So hydralazine is a smooth muscle relaxant, and it acts on just the vessels to try to vasodilate them. One of the questions you can see in your exam is that its commonest side effects will be things like headache, palpitation, diarrhea, and dizziness. And as you have seen, it has caused Lizzie's lupus, which is drug induced. So still one of the treatment for chronic heart failure. Please, heart failure is one thing all GPs must be very conversant about. You need to know it and know it very well. So when it comes to heart failure, hydralazine nitrate is an option. When it comes to heart failure, remember that it's basically, does this patient have reduced ejection fraction or normal ejection fraction? Less than 40 is reduced ejection fraction. 10 to 50 is intermediate, it's just a borderline. Above 50 is excellent or good ejection fraction. The patient's ejection fraction is more than 40. Please, the answer in the exam will be some sort of loop diuretic. Furosemide is a correct option. Bumetanide is a correct option. However, if the ejection fraction is reduced, if you're adding furosemide, please, you must start this patient on first-line guide medication, A plus B. You see, so that's ACE inhibitors or beta blockers. You can start one after another. So if your patient with heart failure has got asthma, please, beta blocker will not be started because beta blocker is a contraindication. However, ACE inhibitor will be started for this patient. Now, those will be the first line medication for a heart failure patient with reduced ejection fraction. Assuming this patient, Liz, comes back to you and says, Doctor, my heart failure is not well controlled with the ACE inhibitor you started and the beta blocker. I'm having shortness of breath, doctor. My ankles are swollen, doctor. I feel horrible. Right in front of you, you measure her JVP, you can see is raised. What do? This is where you go for the aldosterone antagonist. We have spironolactone or we have eplerenone. Both of them will be options for a patient with heart failure. Now, this patient takes that home. She uses it for 2 to 3 weeks. She is not better. What do? She comes back to you. She says, Doctor, instead to work, all of a sudden, I am still struggling. Please, the medication SGLT2 class is one of the medications that NICE have recently added onto the list of medications that can be used for patients with heart failure. Now, remember, they end in the flozins, dapagliflozin. Anybody that is here, just add flozin to the end of your name and you become an SGLT2 transporter, you become an SGLT2. Remember that those medications are notorious for causing urinary tract infections. They cause phonias, gangrene. They cause a lot of candidiasis. But most especially, please don't forget, they cause euglycemic ketoacidosis. So those medications have now become one of our popular medication. Is used in renal failure, SGLT2s. It's used in the management of diabetes and is used in the management of heart failure. Now you've tried for Liz, you've tried on furosemide, it wasn't helping. You even added bumetanide or changed the furosemide to bumetanide, it didn't work. You started on ACE inhibitors because her ejection fraction was low. She still complained. You put her on beta blocker, it's not helping her. You've given her spironolactone, she was allergic. You now went on to give her eplerenone, which is a substitute for spironolactone because they are both aldosterone antagonists. She still came back and said, I'm not well. So you smiled to yourself and said, I know what I'll give her. You gave her SGLT2, canagliflozin or dapagliflozin. Now she's come back to you, you are worried. She's not better. What do? You're very sure that this is heart failure. So you have a chat with the specialist and say, specialist, cardiologist, I've tried for Liz. I've done all these things for her. She is not better. What do I do? Well, before you finish sending the message, they reply you. You've done a request for advice, RFA. They reply you immediately. They say, start, is her heart rate okay? You say, yes, her heart rate is more than 72. They say, start her on digoxin. My friends, digoxin is still a treatment for patients with heart failure. Do not forget. Well, in her usual pattern, Liz comes back to you. She said the digoxin is not working. Of course, you've run out of options here. So you go back to the specialist and say, specialist, your digoxin has not worked. Now the specialist is getting frustrated and say, what type of patient is this? Okay, fine. What descent, which type of patient is this? You say she's African, she's Afro-Caribbean. They say, okay, why don't you start her on hydralazine nitrate? And that's where hydralazine has come from. Hydralazine nitrate is a very good medication, especially for African descent who have chronic heart failure. Hydralazine nitrate remains one of the drugs of choice for a patient with heart failure. Please do not forget, a patient that is struggling with ACE inhibitors, you can use ARBs. If you are using ACE inhibitors, they are not doing well, you can do what we call sacubitril valsartan, brand name Entresto. Entresto used to be the magic medication for heart failure a few years ago, but new medications have come and overtaken it. So when you have Entresto, which is your sacubitril valsartan, you need to remove the ACE inhibitor because Entresto already has valsartan, which is an ARB. Remember, you can't use ARB and ACE inhibitors. It will be contraindicated. Well, there are other things that can be used for this patient, but we're not talking about heart failure today. I just thought to tell you how hydralazine is used in heart failure. Well, when we go to eclampsia, most of you already know the management, magnesium sulfate, 2 grams. However, again, hydralazine is one of the medications that can be used to control this patient's blood pressure. I don't want to go into hypertension in pregnancy. You need to know the 3 types. You need to know a patient that has come into pregnancy with hypertension. So it does mean that patient has essential hypertension and is now pregnant. It's different from a patient who was stable and in the first weeks or the few weeks into pregnancy, they now had pregnancy-induced hypertension. And it's different from a third class of patients. So we're not going to talk about hypertension in pregnancy today, but hydralazine is one of the medications that can be used. By the way, if we are talking about um, um, management of hypertension in pregnancy, then you need to know other medications that are used. So labetalol is used and it was part of the option. It will be the first line. Labetalol, don't fail it. NICE says this is the first line. Others can be methyl-dopa, nifedipine, and your hydralazine. Right? And when we talk about antiphospholipid syndrome, hydralazine, as it causes a drug-induced lipase, it can cause secondary antiphospholipid syndrome. So what's primary antiphospholipid syndrome? No known cause. What's secondary? There are causes. So there are many things that can cause antiphospholipid syndrome, and hydralazine is one of it. I hope now you see hydralazine, you smile, you see a question, they are going towards hydralazine, you are happy because you become a master of hydralazine. Momos. Now, candidates fear cardiology a lot, and cardiology is one of the areas we are just so happy about. We see cardiology, we dance in EasyLearn. Cardiology is very easy. You can see how I wrapped through heart failure chronic heart failure management. This is how EasyLearn candidates do it. It's very easy, very straight to the point. So let's see this question about momos. Which of the following is a pansystolic murmur? Right. Again, please go into your chat box if you know the answer and type it in there. Excellent choice. I think 90% said VSD. So that's very good that everybody's getting very conversant with momos. So everybody has their style of remembering momos. But when it comes to momos, please keep things simple. Momos, so we have some people use past MTIV. Everybody has that. About 6 mnemonics we usually teach in EasyLearn. However, I want to teach this because it's very simple. So pass MTRV is the same thing as pass MTIV. For those in EasyLearn that see it as MTIV. So regurgitation is also can be used as insufficiency. So the R there is regurgitation and the I is insufficiency. It's the same thing. It's just interchangeable. So anytime you see murmurs past MTRV, they are all systolic murmurs. But the question here was a bit odd. If you check, they didn't say which of the following are systolic murmurs. They wanted to know which of them are pansystolic. It means you need to know a bit more than which ones are systolic. You need to know which ones are early diastolic, mid diastolic, pansystolic, ejection systolic, and all that. And this is what we will just use today. One of our mnemonics to take you through. So PAF, what's the meaning of PAF? PAFS. P is pulmonary, A is aortic, S is stenosis. So pulmonary and aortic stenosis are all systolic murmurs. That's PAF. What of MTRV? Mitral and tricuspid regurgitation. Remember, I said regurgitation is the same thing as insufficiency. So don't be confused when you see insufficiency in your exam rather than regurgitation. It's the same thing, my friends. So mitral and tricuspid regurgitation and VSD, that's the V there, are also systolic murmurs. Okay, thanks, Dr. Ola. But that does not answer the question. These are systolic murmurs. Which of them is pansystolic? Well, I will show you. So pulmonary and aortic stenosis, which is the first part, your pass, are ejection systolic murmurs. Is that better now? Right? But Dr. Ola, the question was which is pansystolic. You still not answer the question. Yes, I'll answer the question. Mitral and tricuspid regurgitation alongside with VSD are pansystolic murmurs. Look at how easy that can be for you. Just knowing past MTRV. Right. Now you've talked about systolic murmurs. Let's keep things simple. Let's not go into other systolic murmurs. There are a few others, and there's a mnemonic that covers the other few ones. But these are the popular ones for exam, and we are doing common things because they occur commonly. Diastolic, paid MTS is the opposite of that. Pulmonary and aortic, remember the I can be R, regurgitation, but here I've used insufficiency because the word paid will sound better to remember. That's why we've used it. So paid MTS, pulmonary and aortic insufficiency, are diastolic murmurs. And then your MTS again is your mitral and tricuspid stenosis are diastolic murmurs. So Dr. Ola, in case they ask us what type of diastolic murmurs are they, how do we answer that? Yes, we've got that for you. Pulmonary and aortic insufficiency or regurgitation are what we call early diastolic murmurs. So the first one, remember the paid is early because it comes first. It comes earlier than the MTS. What of mitral and tricuspid stenosis? They are mid. They are in the middle, mid diastolic rumbling murmurs. You see why you can't fail it? Well, a candidate here is saying, Dr. Ola, I saw one about what we call, is it continuous or is it machinery murmur? Yes, I've added it for you, my friend. Patent ductus arteriosus is a continuous machinery murmur, and you can't fail these things in the exam. So when we come into a bit about murmurs, we'll just go a bit on this, just another page, and you should be ready for any exam worldwide. I mean worldwide, I mean USMLE, QE1, whatever exam you want, even if it's a cardiology exam, you should be able to maneuver it. Right, so that's murmurs for you. But you see, tachycardia does come out in the exams, and this is based on Resource Council guidelines. You see, you can't fail questions when it comes to cardiology. Well, if you are shy and afraid of cardiology, then we've come to play around with maybe 5 ECGs and we move to something else.
Hi,
Right.
sorry, Dr. Ola, just 1 second.
Yes,
Can you
go
move
ahead.
over to the last slide,
Definitely.
please? Yes, that's fine.
Definitely.
Just 1 second, please. Just want to grab some.
If you're on the program, we're going to share the slides to you.
Okay,
So
perfect then.
you don't need to write. Please,
Okay, then you
if
can
you're on the
continue.
program, don't write. You know that you get it
All right,
already.
then
Within
continue then.
Yes, tonight on the program, it will be shared via your Google Classroom. So remember that we are running on Google Classroom, and on your Google Classroom, all you need to do is check your email. You will see a link to the videos, and you will also get the slides. Now you now have your username and password on the website. Just log in. Once you get that, again, it will be there for you, and it's
Thank
going
you.
to be there for 6 months. Nobody's going to take it away until we update it. We are removing it because some of these things get old and they need to be updated based on nice guidelines. But we'll
Yeah.
send you the new one if you are still on the program.
Thank you,
Okay,
sir.
no problems. So that's tachycardia. We are going to be rounding up very soon. Next 30 minutes, we should be facing our Saturday and enjoying our day, making learning very easy. So if you know what this ECG strip is, if you can just type in the chat box, I'll be glad. Okay, so we're not going to waste much time. Good choice. Everybody's saying SVT, and that's SVT ECG. So SVT ECG is a regular. You can see if you check if you carry your ruler. So we just make things very practical here. No stories, no cramming. Please, nobody should cram. At the end of the day, if you don't understand something, please ask. And that's why Easy Learn we give enough time for questions and repeat. So don't cram anything, please. So if you take your ruler and you measure between each of the Q to Q or the QRS, you would see that they are all equal. That is what we call regular. Now you can see the QRS is very narrow. That's why we call it a narrow complex QRS. And if you calculate the rate, now someone is asking, how do I calculate the rate? Don't worry, that's why we are here. So count the number of boxes in between the two Qs. So 1, 2, 3, 4. So QRS to QRS peak. If you count it, it's about 4. Divide by 300, it gives you the rate. So that rate, who knows the rate, or can you guys type the rate of this patient, his heart rate into your box? Perfect. So 75. Very easy. Just 300 divided by the number of small boxes, and you get the heart rate. So this is why it's tachycardia. So this patient has a regular narrow complex QRS, but it falls under SVT falls under tachycardia. So this patient has got tachycardia. Sorry, let's calculate that rate again. Sorry. 1, 2, 3, 4. So it's 4 actually. Okay. But anyway, that's an SVT. This guy has got an SVT. So, but the question here, which is going to be the question in the exam, are two. Identification of this ECG and the management of this patient. So you guys have identified it SVT, but how do we manage a narrow complex QRS like this? So remember, this patient will be probably very unwell in your exam or in A&E or wherever. So this is random. This is not how it should go. But remember that the ECG comes first. You do an ECG, or you see on the continuous monitor that this patient has got SVT. What do? You want to arrest the SVT. So some people do vagal maneuver, you do Valsalva maneuver, whichever one, please try and arrest this so that it doesn't get worse, because this patient can become rapidly unstable and become unwell. So vagal Valsalva maneuver, different ways to do it, blowing into straws, carotid massage and all that. Whatever vagal or Valsalva maneuver you want to do, you just do that. You continue to check the ECG to see if it's getting better. Not getting better, please switch to medication. Adenosine, please do 6 milligrams first. Increase 12 milligrams, increase again by another 6, 18 milligrams. If this is not working, you can abandon adenosine. Beta blockers can be an answer. the beta blockers that will be the answer in your exam, please think about your cardio-selective beta blockers. They can be used. Now, just for people who will forget that carotid sinus massage can still be used, although it doesn't always work, which just puts it there. And verapamil is one choice in the United Kingdom. Verapamil is something that people like to use. So people have tried adenosine. Rather than try any other thing, they go straight to verapamil. So what do you do with verapamil? You just give it at the recommended dose, and these patients get better. So that's SVT, quick management. We've got something a bit much better on the program for you to help as a remembrance aid. But just for this, we're doing SAVE ABCD. So, but this is another ECG. Who has a clue to what this ECG is all about? Anybody? We have, by the way, we have an ECG course that's going to be taken soon. So we have 2 ECG courses, and on the program we have ECG teachings for those writing the exams. For the AKT, you would notice that 1 ECG comes out on average on every exam, 1 ECG per exam. So it's good to know ECGs. On the QE1, you may see up to 2 ECGs on your exam. So it's always good to know them. Okay. So yes, chat box. What do you think that ECG is? Atrial fibrillation. Yeah, most of you typed in AF. Good job. So that's an AF ECG. Again, this is narrow complex QRS. So someone say, what's the difference between the first one? This is also a narrow complex QRS. Okay, so that's regular. Now you see the difference. This is irregular. So SVT regular, AF is irregular. Of course, I'm not going to waste too much time so that we can go away today, this morning. It's just your beta blockers. So rate control is what we do mostly. People don't do much of the rhythm control. We leave that for the specialists to do. Remember your beta blockers. However, your rate limiting calcium channel blockers can be an answer. So verapamil, diethiazem, if need be. Remember that for people with heart failure, amiodarone or digoxin is also an answer. Okay. Remember that you need to also do your Chadvac scoring, and it's no longer Hasbled. It's now Orbit. So for you guys that still are carrying old stuff around, Hasbled has been changed. You need to know what the Orbit score is. That's the risk of bleeding for this patient. Chadvac, we teach you how to quickly do it in five seconds for your exam, how to calculate it. And if this patient is having AF for more than 48 hours, then this patient needs to have a Chadvac done and placed on anticoagulant if needed. What's this? What ECG is this? Okay, quite a lot of people are not sure. Some few people boldly wrote Tosa de Pointes. Well, this is what we do on the ECG course. We tell you how to identify it. We're not doing that today. For those who know it, that's good. For those who do not know it, on the program, we'll tell you exactly what to watch out for, everything, all the points and all that. So don't worry about that. But if you know it, Tosa de Pointes is polymorphic VT. Polymorphic VT. So PVT can come out in your exam. So, okay, so this is VT. This is VT, sorry. So we're going to see Tosa de Pointes. We're going to see Tosa de Pointes. So this is ventricular tachycardia, a VT. Now, the similarities between polymorphic VT, that's Tosa de Pointes, and a VT is that they are broad complex QRS. So look at the QRS. You can see that is way larger than the ones we saw earlier, which are narrow complex. So let's look at that again. See how tiny they are? Can you see? So you are seeing tiny QRSs like this. Can you see how small the QRS is? So small narrow QRS compared to what I call fat, broad, big-sized QRS. So this is your ventricular tachycardia. Well, this may have thrown some people off balance, but again, we're going to teach you about that. So VT, it's a broad complex QRS, and this is regular. The difference between this and torsades de pointes is, okay, that's the treatment, but torsades de pointes, irregular. So you can see the difference. One is regular, the other one is irregular, but they're kind of very similar. We'll also bring classical ECGs, which is what you see in your exam. So don't worry about that. You'll see ECGs that will be similar to what you see in your exams. But what we are concerned about today is management. So how do we manage this condition? Amiodarone, 300 milligrams. Please give IV over 10 to 60 minutes, slowly. Don't push amiodarone 300 milligrams over 5 minutes or over 8 minutes. It's over 10 to 60 minutes, and candidates fail this in the exam. Okay, so the same thing with polymorphic BT. If you know the management, you can type in the chat box. So for torsades de pointes, polymorphic BT is your magnesium sulfate. I've talked about magnesium sulfate in the management of eclampsia. So it's also used here, and is also used in asthma. See, you can't fail these things in the exam. So you see that, you get that. Yeah. Is there a question? Okay. Right. So when it comes to tachycardia, some patients become unstable, and the Resource Council wants you to be able to manage these patients. So they come out in your exams, and that's why you need to have an advanced life support before you come into GP training or while in your GP training. So first of all, every patient that has a regular rhythm, that's VT and SVT, if you've tried everything and they are not working, you've got a lifeline, something to fall back on. And that will be to do what we call a cardioversion. So DC shock, you do 3 attempts. That's DC cardioversion, 3 attempts, and that should help. Otherwise, be referring this patient to the cardiologist. The other one is if presence of life-threatening features, so we'll put them for you as 4 S's so that you remember. How it come in the exam is they'll write that the patient is now in shock. They won't put shock, but they'll put features in keeping with shock or syncope. They'll say he's fainted, or he has severe heart failure. They'll put ejection fraction there, or they will announce you in the question that he's got a sudden heart attack in the past, or he's had it just now. So if he's had a sudden heart attack now, it means this patient is unstable. If he's in shock, he's unstable. If he's had syncope, he's unstable. If he's having heart failure symptoms, he's unstable. Again, synchronized DC cardioversion or DC shocks up to 3 attempts will be the answer. Okay. So this patient suddenly collapsed. He was talking to you, he's a GP trainee, was just having a chat with you. He suddenly felt cold. He collapsed. Can you put the diagnosis and the treatment? You've got 30 seconds to do that. Yeah, if you put complete heart block or 3rd degree heart block, you're right. Well done. Well, please, I tell everybody in EasyLearn and outside EasyLearn, you see a patient, you've done this ECG, the patient is saying, doctor, I don't feel very well, but I think I'll be able to go home. This patient is right seated in front of you in your GP practice. Don't offer this patient a cup of tea. This is not the patient to talk about the Manchester United Fulham match with. No, this is not a patient to be talking about some other interest. This is not a patient to have a chat about anything. This is a patient where, as the patient is in front of you, you are sweating, you are picking up the phone, you are not even telling the patient too much. You are just telling the patient, I'm sorry, your ECG is not very good. I need to phone the ambulance. You see, you're phoning the ambulance. If the nearest hospital is far away from you, you are requesting a blue light ambulance. And if it's too far, if you live in a remote or work in a remote area, you want a helicopter to come in to pick this patient. Third degree heart block can become a disaster really quickly. And these are not the patients that you should be having a chat with. It's a nightmare if this patient does collapse. The chances of this patient dying is very high. So if you've got atropine in the practice, why not give this patient? Because I've not calculated that heart rate, but that heart rate looks terribly slow. It is pretty slow. So if this patient is in front of you, you are seeing this heart rate, maybe 30 something. I don't know who has calculated it, maybe 20 something. Just recently, last month, patient came to me and says, I've not been feeling well, doctor. He was telling me about diarrhea. He was telling me about headaches. He was telling me about lightheadedness. He was telling me about ear symptoms. So trying to throw me off track with his ear symptoms. So, vertigo plus ear symptoms, that can be labyrinthitis. That can be vestibular neuronitis. That can be BPPV. That can be one of the ear problems. I said, fine, let's take your heart rate. So I took the regular SpO2 device, which all of you have. In Boots, it's 20 pounds if you don't have one. Put it on his hand, and he was showing me 31, 29. I was very suspicious. So I decided to take it manually. I even got something lower. I got 26, 27. It was irregular. That day, I didn't wait for any ECG. While we're getting, I told them to bring in the ECG, but while they were bringing in the ECG, I was phoning the ambulance. When I was done with the ambulance, I was phoning the hospital. I was telling them, please prepare for this patient. I've seen a heart rate of 27. I'm very worried. They didn't ask me too many questions in the A&E because they do understand that this patient can deteriorate very quickly. So I think I've emphasized how important third degree heart block management is. So give this patient atropine. You don't have atropine or atropine is not working, isoprenaline is on the Resource Council guidelines. It's still being used. Well, it's not working or it's not available, or the pharmacy says we've run out of it, we've not had it for 6 months. Adrenaline is an answer, you see. So you've got a couple of options. But the question in your exam is, what is the definitive treatment? Can you put in the chat box if you know the definitive treatment for this patient? Excellent. All of you got the answer, is a pacemaker. Now there are different types of pacemaker. Please do not pick transcutaneous pacemaker in your exam. You will fail that question. So you need a permanent pacemaker, transvenous pacemaker for a patient with third degree heart block. I mean, you can put a temporary TV pacemaker until he goes to a cardiology center, a cardiac center, to have a permanent pacemaker put in place. Right. So this is Matilda. Matilda came to your office crying, you see, 27 years old. She's very emotional. Her boyfriend sees what's on her leg, he's left her. You feel very bad for her, you see, you're not very happy. That's Matilda's leg. Matilda, when you were talking to Matilda and you were looking at her leg, she just suddenly started crying. You looked at her eyes, and what did you see? You saw that, you see? That's Matilda's eye. Now, Matilda is not worried about the eye because she doesn't even know if there's a problem with her eyes. But you have seen that, you see. But while you were looking at the eyes, you looked around the eyes. You are looking at her now very keenly. You want to know these things, this eye and this leg, are they connected? So you look at her face for the first time really well. Not because you are checking if she's beautiful, but to check for other signs and symptoms. What do you find? That's what you find. Now, you are connecting the dots. You think A and B and C are connected. If you know the answer, if you know what's happening to Matilda, please tell me what is A, what is B and what is C, and tell me what may have led to it. Please put that in the chat box. Thank you. Perfect. So many answers. Familial hypercholesterolemia, correct. Hyperlipidemia, signs and symptoms, correct. Whatever you say, correct. But again, have you put up picture A's answer? Because the overall diagnosis is different from the clinical signs and symptoms, which are right in front of you. So yes, if you put familial hypercholesterolemia, where it may be, if the question does come out to show that, so you need to read the question. But then these are clinical signs of hyperlipidemia. Right, so picture A. I saw some people put xanthoma, correct? Well done. Excellent. I saw someone put acute acute, any acute you put in, please check, is it the cornea or what part of the eyes is affected? So this is acus cornealis, right? Okay. And I've seen some people put xanthelasma. Okay. Well done. Excellent job. If you got 3/3, you have done very well. If you got 2/3 or 1/3, you've learned something new. If you got 0/3, congratulations. You've learned so many things today. So the question here is, how do we manage this patient? This patient will probably need some sort of lipid lowering drugs. So first of all, what do you need to do? A lipid profile. Well, it's possible that it will come out above 5. What do you want to do? First line, please, statins. Ezetimibe will not be the answer in your exam. It's an add-on. You will fail the question. I'm sorry. You will not get that question. Statin will be the correct answer in the question. So if you do see questions like this and they're asking for first line treatment for a patient using lipid lowering drugs, please use statins, not any of the other lipid lowering medications. So when we come to lipid lowering medications, well, I don't want to go into that because we will need to talk about 4 of them or 5 of them that are quite popular. But I'm just very curious to, or I would like to talk more about statins. So let's talk about statins. When it comes to statins, everybody needs to be clear about the kind of questions they ask regarding statins, whether in the QE1 or in the AKT. I'm just going to focus on the AKT. The first thing you need to know is, what are the types of statins? So you see, statins can be lipophilic. Or before I go into statins, someone says, what are these things on our screen? Can you describe them a bit more? Right. Xanthoma. A xanthoma is just a fat buildup. So that's fat buildup under the surface of the skin, or sometimes you can see it physically like that. So that's a very bad xanthoma. Xanthosoma are a type of xanthoma, but they are appearing around the eyelids. So C is a type of A appearing around the eyelid, while your acus cornealis is a lipid deposit that appears in rings on the outer region of the cornea. It's usually gray or white, and it may not be related to hyperlipidemia. But in this patient, because you can see that she's had xanthoma and xanthelasma, then it is related, and it's probably due to hyperlipidemia. Are they harmful or harmless? That's one of the questions this patient may ask you. They are harmless and they can improve, they can go away. For the xanthelasma, there are 2 types, although I don't want to go too deep into this because it's just meant to be just a bit surface and soft. So macular is the flat type, and eruptive is the one you see on your picture, the raised type. Now back to statins. So statins will be something that we may be prescribing for this patient. Of course, there are indication for statins. And someone was asking me last year, someone on the AKT program, when do I prescribe lipid lowering statins, and when do I prescribe the other types of statins? So water loving statins that's hydrophilic statins, are different from fat-loving statins, that's lipophilic statins. Lipophilic statin, remember the popular ones with AS, atorvastatin, simvastatin. And the hydrophilic, that's the water-loving statins, they are pravastatin, rosuvastatin, all the other popular statins, are probably going to be water-loving statins. Now, you can see a question in your exams, in your AKT, which of these statins has been linked to cancer risk in patients that are elderly or patients over 65? It is pravastatin, my friends. Don't fail that. Do you need to do a Q risk for this patient? Please, if you've not done a Q risk in real life, you've not completed your assessment. In the exam, if you do not pick Q risk, you fail the question, you see. Right. So we've known the two types of statins, water-loving and fat-loving. What is the difference? The fat-loving statins are cheaper in the UK on your CCGs. In fact, I can give you the price of a pack of atorvastatin. It's about £1, just slightly less than £1. So it's in pence. However, I can tell you the price of your pravastatin is about £20. It's a lot expensive. Rosuvastatin is about £9. You see, it's almost 9 times the price of your atorvastatin. Now, someone is asking, why are you telling us the prices? Are we sales reps? No. It's now telling you that one of them will be first line. Of course, the cheaper one is the first line. So your simvastatin and atorvastatin, because they are cheaper, they are first line, and because they are also effective, they become widely accepted as first line. What's the problem with them? The problem is they cause what we call myopathy, statin-induced myopathy. Myopathy, muscle pain, they cause myalgia. It can happen in the night, it can happen in the daytime, but it's common at night. So what do you do for this patient? You may want to switch the time they use it. So that's your atorvastatin or simvastatin. You've switched it, this patient is back, says, doctor, I can't tolerate this medication. Don't give up just like that. Calm down, tell them how long have you used it for. I've used it for just a week. Say, can you try a bit more? Sometimes if you try it a bit longer, these symptoms tend to fade away. Patient comes after 2 weeks, says, doctor, I've tried, I cannot. What do? Switch from the lipophilic statins, which are known to cause more statin-induced myopathy than their counterparts, the hydrophilic statins. So you switch to a hydrophilic statin like rosuvastatin. So you've switched to rosuvastatin, the patient is still complaining. Doctor, thank you for switching me to rosuvastatin, but this leg pain, this myopathy that you described to me, I'm still having it. This is when you need to check. Is this patient doing other things that could worsen their myopathy? First of all, is the patient female? Female patients are more prone to myopathy. You can't change that. That is what we call a non-modifiable risk factor. Well, is this patient also elderly? That again is a non-modifiable risk factor. And there are a few other things. Does the patient have diabetes? They are more at risk of myopathy alongside using statins. However, if this patient is on antibiotics, maybe for her face, she's using lamicycline or erythromycin for 3 months because she's got acne, what do you think? Yes. So you got the gist there. Macrolides can significantly worsen myopathy, so they need to stop the statins temporarily, finish the antibiotics, and they may feel better. What else? Are they pregnant? Well, pregnancy, statin should not be stopped until patient completes the course of pregnancy. But in terms of pregnancy, please, these are some of the things that can worsen statin-induced myopathy, because on their own, they can even cause some sort of muscle tension. Right. In terms of investigation for statins, LFTs, please do at baseline 3 months and 12 months is very important. The other thing to do is their lipid profile, of course. You need to do the lipid profile. Now, moving on to other parts or other things you should know about statins, you should know about the indication. Why are we giving statins? So there are two indications. Is it primary or is it secondary? Secondary is someone that has had an established cardiovascular disease, such as stroke, maybe ischemic heart disease, a TIA, peripheral artery disease, or all that. But primary will be just what we call primary prevention. Q risk greater than 10%, it will be greater or equal to, please. So 10% is part of it. In a patient that has that Q risk, then you probably need to start them on statins. But remember, any patient that has type 2 diabetes should now have Q risk 2 assessed. In the past, they didn't used to have it. NICE guidelines says they should have Q risk assessed, and we are now moving to Q risk 3, my friend. So if you've not started using the Q risk 3, please start using it. But they should have their Q risk assessed and see whether they need statins. For type 1 patients, they fall under primary prevention if they have had type 1 diabetes for more than 10 years, or they are over the age of 40, or they have nephropathy. So these are some of the things we need to know about statins. Of course, on the program, we'll teach you how to adjust statin dose via calculation and a few other things. Right, so this patient has come to you. She's 16 years old and she wants to kill herself. She's taking overdose of aspirin. So aspirin overdose, how do you manage her? Well, I know some of you or most of you already know how to manage that, but I'm just going to, because of time, we're wrapping up in 5 minutes. I'm just going to go through it. The main medication you need to know is sodium bicarbonate for your exam. So aspirin, overdose management, sodium bicarbonate. Aspirin, sodium bicarbonate. Please don't forget that. Of course, depending on how much they've taken and how unstable they are, airway, breathing, circulation. For the circulation, don't use normal saline. That's another pitfall. Is dextrose infusion. Do their ABGs, LFTs. So aspirin greatly deranges LFTs. That's liver function test. So you need to check liver function test at baseline. Repeat in 3 days. Repeat in 1 week until it goes back to normal. Check aspirin level, of course. An aspirin overdose can bring down potassium level, so you may need to give KCl. In the UK, the use of activated charcoal has reduced, but if you catch the patient within 1 hour, this can be an option. These are the A's, the 5 A's of aspirin overdose management. Right? If you think it's hypo or hyperthyroidism, well done. You're correct. That is one of them. So this is hyperthyroid crisis. So this patient has got hyperthyroidism, but unfortunately for her, is even worse than what it used to be, which we call severe hyperthyroidism. So what do we need to know about hyperthyroid crisis, or what we call thyroid storm? Yeah, I'm just going to take you through because of our time. So when it comes to hyperthyroid crisis or thyroid storm, there are a few things you need to be clear about. So let's look at the A, B, C, D, E, and E to I, or to yes. So first of all, again, it is a medical emergency. So this patient needs to be not in your GP practice chatting with you, no. Not you offering them a cup of water because they are coughing, no. They should be at the back of the ambulance, racing to the hospital, already in hospital. In the hospital or in the ambulance, ABC should be done if needed. And the main thing will be to try antithyroid medications. However, it doesn't always work. Remember that their heart will be racing fast. This is where propanol or beta blocker comes into play. You need to do your blood test, full blood count, CRP, because infection is usually a trigger. And don't forget to do your thyroid function test. They will have a lot of CNS symptoms like confusion, coma, all sort of memory problems will come up. Then diarrhea, vomiting, and abdominal pain will be one thing to trigger to say, well, we are likely dealing with a thyroid storm. If there is a thyroid storm and there is no hyperthermia, then the diagnosis is wrong. Temperature of greater than 40 degrees Celsius is what we expect in a patient with a thyroid storm, or the other name is hyperthyroid crisis. So if you are not seeing this, then you're probably dealing with another diagnosis. In the AKT question, pick an alternate answer. Of course, the only cause of a hyperthyroid crisis is because there's an uncontrolled rise of T3, T4, which is what we call severe hyperthyroidism, right? These patients are usually patients with either Graves' disease or toxic multinodular goiter. Please don't worry about these big names. We break it down under endocrinology into simple terms. We tell you everything about them, and you should be happy to pass the exam easily. So these are usually what their past medical history will say. They either have Graves or toxic multinodular goiter. Now, there's a laboratory part of this condition which has to be confirmed. You may see hyperglycemia, or you should be looking out for hyperglycemia because 90% will have it. Hypercalcemia will also be there. And of course, I've talked about LFTs at the range, what we call hepatic failure. Tachycardia is another thing I talked about, and that's why we're using beta blockers. So they may have AF, increased irregular heart rate. How do we manage them? Definitive treatment is to use PSI. Steroids, you can use your dexamethasone or hydrocortisone, whichever is available to you. Both of them are acceptable in the United Kingdom. When it comes to using iodine, the common one in your exam is Lugol, Lugol, Lugol iodine. However, if you can't lay hands on any type of Lugol iodine, that means it's not in your option. Sodium iodine or potassium iodine are correct answers in your exam. And of course, your antithyroid medication, which we started with, can be your propylthiouracil or your carbimazole. Remember that this patient needs general measures, so cooling blankets, antipyretics, and all that because of the temperature. Don't ignore that. That can cause their death. So just make sure that you're also doing symptomatic management while trying to do definitive care. So that's hypothyroid crisis for you. No need to stress yourself. Know the A to I of it, and you should be fine for your exams. That's hypothyroidism. This is Jane. I would have loved to tell you about the question, but there's no need. Let's just go through. So, low TSH. Okay, let's type in the chat box within 10 seconds each. If you see low TSH, low T4, what do you think is happening there? Low TSH, low T4. Diagnosis, please. You have 10 seconds. So 9, 8, 7, 6, 5, 4, 3, 2, 1. If you have no clue, we're going to teach it in endocrinology. If you've tried but you failed it, don't worry. It's good you attempted it. It is secondary hypothyroidism. Low is secondary. It's from the higher centers. You see, everything is low. Secondary. There's something causing it. Secondary hypothyroidism. We'll explain that a bit more. Now, high TSH, low T4. You can type that in the chat box if you know the answer. Where the TSH is high, T4 is low. 9, 8, 7, 6, 5, 4, 3, 2, 1. Excellent. So if you put that this is primary hypothyroidism, well done. This is an overt primary hypothyroidism in this patient. And how about high TSH, normal T4? 5 seconds. 5, 4, 3, 2, 1, 0. Right. Excellent. For all those who chose subclinical hypothyroidism, well done. If you got 3/3, you're doing very well. You just need to start looking at the applied questions. If you got 2/3, you just need a bit more work and you should be fine and all home and dry. If you got 0/3, congratulations. That's why you're here. By the next time you're seeing this, you'll be getting 3/3. Right. So diagnosis was made at day 5. Who wants to try this? I'll give a bit longer. Diagnosis of hypothyroidism was made at day 5. What do you think the answer is? Okay. So if you said, well, this child is day 5 old, is 5 days old, and they've made a diagnosis of hypothyroidism. Yeah, correct. Congenital hypothyroidism. Please, Hale prick test is how we do this. This is the newborn screening program, monospot test. Don't fail it. HMG pick. Remember all the conditions that are screened from day 5 to day 9 on the monospot test. That's the newborn screening program. So your hypothyroidism, congenital hypothyroidism is there. You'll remember that your maple syrup disease is there. Remember that your medium chain acetyl-CoA is also there. Remember that this phenylketonuria is one of them. Isovaleric acidemia is part of it. Gluteryl aciduria is also there. Remember that this patient, they may find that they have sickle cell disease. So remember all of the components of the monospot test, HMG PICC, PICC, and with the S at the end for sickle cell. So we teach all these things on the program, and you should be home and dry. So treatment is levothyroxine. Remember that if there's anti-thyroid peroxidase antibody, you can see that in 3 conditions. Anti-thyroid peroxidase antibodies is present in grapes. Anti-thyroid peroxidase antibody is present in postpartum thyroiditis, and anti-thyroid peroxidase antibodies is present in Hashimoto's. Now, for Hashimoto's, how do you know that it's Hashimoto's? You see a hypothyroid picture. So hypothyroid picture plus anti-thyroid peroxidase antibody equal to Hashimoto's. A hyperthyroid picture plus anti-thyroid peroxidase antibodies, you are likely dealing with Graves' disease. Treatment for subclinical hypothyroidism. If the TSH in your question is greater than 10, please treat the patient. However, if it is greater than 10 and the patient is greater or equal to 80 years old or an elderly patient, they are asymptomatic, please just monitor. You don't need to treat them. If they become symptomatic, go ahead and treat or speak to specialists. TSH is high, so it's greater than 4. Remember, normal TSH is 1 to 4. These are some of the things we teach on the program. So normal TSH 1 to 4, that's the one your MRCGP AKT uses. So if it's more than 4, it's high, but it's less than 10, you should only treat if they are symptomatic. If they are asymptomatic, do not treat. So that will be your management for your subclinical hypothyroidism. Okay. So this is Brenna. Brenna is this patient that has been sleeping all day. She's been unwell. She's had a bit of constipation and all that. She's come to the hospital via the ambulance because she's really, really unwell. If you are guessing correctly that Brenna's constipation, drowsiness, you can see she's sleeping all day, fatigue, feeling very tired, is due to hypercalcemia. Well done. Very good. Very good. Right. So let's look at Brenner's case. For hypercalcemia, if they've got severe hypercalcemia, as evidenced by a value greater than 3.4, which is severe, you need to be admitting them. So admit, they need IV fluid and IV bisphosphonates. That can be your pamidronate or zalindronate. If it's mild to moderate, you need to check, do they have cancer? So cancer changes the whole picture. So mild to moderate with lung cancer, mild to moderate with any type of cancer is a 2-week wait to specialists. If it's mild to moderate without cancer, you may be able to manage this patient in the practice with oral medication. If a patient has got hypercalcemia, concentration of greater than 2.6, then we are dealing with mild. So that will be the cutoff of low, and the cutoff of severe will be greater than 3.4. Now, let's do the last question. Illness trajectory. So that's your question. Please put the right answer in the chat box. Right. I've seen a lot of B's. I've seen some C's. I saw maybe one or two D's, and some people think it's cancer. Right. So we've got a death trajectory video, very good one on our YouTube page. Please go to the YouTube page. It's about three minutes or 4 minutes. It's got a big net, so it's got a scenario case for each of them. So I describe this as a bumpy ride to death. You can see it's very bumpy. So at the top there, where there's function, that's when he was well. Then the first bumpy ride is when he landed in hospital for the first time. They said, Mr. Smith, you've got heart failure. Like, heart failure. Anyway, they give him ACE inhibitor, he gets better. He goes home. Within about 2-3 weeks, another bumpy ride. He falls into another pit, which is hospital. They give him beta blocker. Says, okay, fine. He gets better. He goes home. You can see each bumpy ride is getting shorter. The last one was 6 weeks. Now is 5 weeks. Again, he sleeps down, jumps into the hospital. They give him spironolactone and epinephrine. Well, he goes out, he's well. Again, 4 weeks, he's back to hospital. This time they give him digoxin. It goes away, and that's the end of Mr. Smith. He falls to the end of the line, all-time low in function. The lowest level of functioning is death, is 0 functioning. And the time it has taken to get to his death is what you can see there. I call this a bumpy decline to death. It only happens with organ failure, like lung, heart failure, and all that. So that's what has happened to, sadly, to Mr. Smith. Let's look at how the cancer death trajectory or illness trajectory come. Let's also look at the dementia one. So that's it, my friends. So this first picture is a patient that had a car accident, or he was well. He was talking to you. So we'll see later. Yes, you're going to play tennis. Are you okay? Yes, I'm okay. Yeah, okay, fine. We'll see. You hug the patient. The patient leaves you. 1 hour later, you hear the patient is dead. That's sudden death. Trauma, all sort of accidents are responsible for the death trajectory in picture one. It's just all functioning fine and it drops off the cliff. Sad. This is the one people are surprised. When someone says, I'm very surprised at what happened, is the first one. You see? The second one, well, this patient knows the patient has been sick. The patient has been unwell. And this is where cancer comes in. So they've got a terminal illness, mainly cancer. And all of a sudden, this patient becomes unwell. They know it will happen one day. In fact, the doctor says, I'm giving him 6 months. But on the fourth month, he was doing well and he just fell off the cliff. Well, it's not always a straight death. In the first one, they die immediately because the car crushed them, so they died immediately. But the second one, they didn't die immediately. His wife called, doctor, nurse, please help. So the doctor and nurse come in and they put oxygen and they've tried some other things. So he's still awake, he's still alive for a few hours, but he still dies that same day or the next day or 3 days later. That is terminal illness. Now, see the one that came out in your question, organ failure. It just keeps going, like it's like renal failure, lung respiratory failure, heart failure. It just keeps going until that organ can have no more. The organ says, Mr. Smith, I'm tired. I need to go and rest. And that organ is vital for Mr. Smith's survival. So he dies. That is a bumpy decline to death. Frailty, they're already down. You can see how low they are. So for those who chose dementia, you can see, I can see the zigzag tracing on the graph, and that may have confused you. But look at it, it's already down. Someone who is frail is frail. They are already, the thing about frailty is they live many years. However, they are already poor functioning. Their functioning is already almost at the lowest level. It's just second to death. So dementia, frailty, they can't do anything on their own. They're probably, in terms of function, maybe two function or one function. And that's why the last is frailty. So that's the illness trajectory. And we're going to end here. Some of you have questions. You can have questions about our teachings today. You can put on the groups or you can quickly ask here. Some of you have questions about the program. Some of you are on the program and still have questions. This is the orientation of the program, so it's not meant to be a proper teaching session. So you can ask your questions here about what you are confused about. Some of you are just passing by and you want to see how the program is and see whether it's the best program for you. Please again, ask your questions. So the questions here are about the teaching today, about the program, or about anything related to EasyLearn. Okay, we'll have 5 minutes for questions because we've gone past our time and we end at 10:40. Any questions, please? For the guys that were asking about, please, you need to just unmute. Feel free, don't say your name, just unmute and ask your question. For the guys that are asking about the GP Classroom, admin, can you put the link back for the GP Classroom? The GP Classroom is completely free. The questions there, I think it's 5 nights every week. It's completely free. It's from one of the question banks, and it's just for you guys to get acquainted to how the exam question comes. The only times it won't hold will be when we're having a program like this. So it will be cancelled so that that program can hold. Otherwise, it's free. On the GP Classroom, you also get flashcards from time to time. Not as much as the type of flashcards on the main program, but you will get flashcards. On the GP Classroom as well, you can discuss and ask questions about things concerning your GP training with other people on the program. Also on the GP Classroom, if you have all other general questions about training, it doesn't have to be clinical. You can ask about that as well. The GP Classroom has got basically admins that do not necessarily help you do much. So it's a free group, which means you are in control of the group. So that GP Classroom is just for support and nothing more. Yeah, questions, please.
Thank you very much, Dr. Ola. How do we join the January classroom, the January for AKT?
January cohort. Okay. So the general, you can join now or you can join 3 months to your time. So if you are joining now, you'll be joining a non-AKT package, which helps to prepare you for the exam. So you are not under any pressure before your exam. When you join now, you will be learning at your own pace without any pressure. Because what happens when you join an AKT package is that you're under a lot of pressure, which is what the exam is all about, a lot of pressure as well. What we do is when it's time for your exam, 2.5 months to your exam, we migrate you away from the general teaching group, and which is a general drill group. We migrate you to the AKT group. And depending on the package you choose, many packages have a free of charge migration, so you don't have to pay to migrate to AKT. However, if you are on a package that needs migration charge, you'll be told. So you just need to message the admin and tell them when you want to join. If you want to join now, then you'll be told to join a non AKT package, which will help you greatly. At least you'll be 60% or 70% ready for the exam. So when it's 2 months to your exam or 2.5 months to your exam, we do the rest. We'll bake you for the exam. So yes, admin, please put up your numbers so you can message them on WhatsApp. If you go onto the website, you see another admin number. There are about 2 admin numbers on the website. You can contact any of them, but there's one active admin who spoke to you, and that's our HR. He will help you sort out things really quickly. Any other question? I can't see the chat box, sorry. So if you unmute, or if admin, if there is anything in chat box, you can just ask me. Or if you unmute and ask your question. Yeah.
The program, what is the schedule like? What days
No, so that's what was put at the beginning of this. Let me see if I can let me just end slideshow from beginning. So it depends on the program you are coming for. Every program is different. So if you're on Epic, so these are our programs. Epic is for ST1s. Your program for Epic is running over 2 years. and it's not just about clinical stuff. It tells you about when to do your minor surgery, tells you about road to Dubai, road to Canada. You are free on the ECG courses. Any ECG course we are doing an ECG course very soon. Epic gets it for free. They get their certification. We do an ABG teaching course. Epic gets it. So if you're on Epic, your rota is a 2-year continuous rota, which is different from Prime Plus, which is a ST1 program for 6 months. They have their own timetable separate. So it depends. You have to now tell us what program you have chosen, or you have to speak to the admin to choose a program for you. So we've got a program booklet. Admin, can you put the digital program booklet on the chat box or on the GP Classroom, so that everybody can have a look at the digital booklet? If you're on the AKT, it's 2.5 months, unless you join Pass Premium, which is a 6 months program. SCA is different. So yeah, so those are the people in ST1 and ST2. You've just got 3 programs: Epic, ST1, Prime Plus, ST1. Sorry, Epic is ST1, ST2. Prime Plus is ST1, 6 months, first 6 months or your second 6 months. But we'll do say that if you are just joining GP training, the best program for you will be Prime Plus, because it's got 20 hours of one-on-one portfolio support with our portfolio experts, Dr. Farouk, Dr. Ogali, and we've got the other person, Franklin. So we have that on Prime Plus, which Epic doesn't really have. When I say one-on-one, all you need to do is go onto our website, choose the time you want. Maybe you want Saturday, 8 p.m. So you just go Saturday, 8 p.m., book a time. It sends a message to your e-portfolio tutor. And then on that day, both of you are on and you start your discussion. But that 20 hours can be used for other things. It can be used for advice, can be used for other things. Some of you on the call are on that, and I've gotten feedbacks that you've greatly enjoyed it. So that's what Prime Plus has that Epic doesn't have. Otherwise, Prime Plus is 6 months, Epic is 2 years. For the AKT packages, please, there's Pass Confidence. I don't want to talk about all of them. They're all on the group. Pass Confidence, Pass Guarantee, Pass Plus, Pass Premium. If you're on those AKT packages, and if that's what you're asking about, this will be your timetable. I'm just going to show you how the timetable will look like. This is how the timetable does look for people on the general program and the AKT drills. So, but then it will slightly be different, because if you're on a different program, you may get request prompts from time to time to join a different classroom based on the program you are. You don't need to worry about that. You'll be getting prompts ahead of time, and you get on your email, you get links to join ahead of time, so you will know where to be at every point in time. So, but that's how it goes. That's the timetable for the person that was asking, how does it work? It's usually in the evenings, unless on the weekends, and the lectures are recorded apart from the drills, and special programs are open to everybody. So if it's a paid special program and you're on Easy Learn, you get 80% of all the special programs free of charge. Epic gets 100% special program free of charge. And that's how the thing is. If you're on AKT package and it's not your time for your AKT, you'll miss a lot of special programs. So we do want people who are not writing the AKT to join a general package, because the general package, which is your Epic Prime Plus, you will still be in the AKT classes. It's just that there won't be any pressure on you. But once you decide that you are going into an AKT class, you'll be under a lot of pressure and will have to remove everything non-academic, everything non-AKT preparation away from your package, which means you'll be losing a lot if you're an ST1 or first part of your ST2 and you are not ready to write exams. I hope I've answered the question for that candidate. Any other question, please? We've got 2 more minutes, I think. Okay, 1 minute actually. If you have any question, you can ask. Otherwise, please drop your questions on the GP Classroom. If you are not on the GP Classroom, which is a free classroom, please, admin, put that link again and let them join. If you have written your AKT and you should not be on the GP classroom, you should be on the post, that's the SCA, post SCA classroom, or on the SCA classroom. Those classrooms are for jobs. You see a lot of high paying jobs there. And we'll soon start dropping our partner advert on those classrooms. So if you're going to Canada, Dubai, you're going to Saudi Arabia, Oman, we've got a partner in Oman that is paying really, really well. And we are trying to see how people can go to islands in South America. You will not see them on the GP classroom. You need to be on the post SCA group or on the SCA group to see jobs, because that's the level at which you are. Again, if you've passed your AKT, you shouldn't be on the AKT GP group. You should be migrating. So I'll tell the admin to drop the link on the GP classroom. Please migrate away. You will not be added until you show us evidence that you've passed your AKT. So if you have not passed your AKT, don't bother going to the SCA classroom, please. It's of no use to you. If you have not written, if you are just not written your MSRA, you are planning to come into GP training and you are here, please, you should be on the MSRA GP classroom. So the MSRA GP classroom 1 and 2 are filled up, I know, but we have the third one, which has a capacity of 1,200, and I'm still aware that there's space. They do question nights, they do a lot of MSRA related stuff. You should not be on the AKT class. So this GP classroom is for people writing the AKT alone. If you have written your AKT, please don't join that group. And if you're on that group, migrate to your group. If you are a GP already and you are here, please join the post GP. So that's the GP post classroom, which is about having to things about your the different contracts. If you feel you are cheated, new jobs for you as well, come on that classroom. How to start up your practice. You want to start up a practice, you're moving to the United States, you want to find how to register. That's what happens on that platform, that classroom. So there's a classroom for you. So please, everybody should identify the correct classroom, because I see some people, they are doing questions on AKT questions on the GP classroom, which is our AKT classroom, but they have written AKT. So at the end of the day, they're just filling up their phones with a lot of messages and getting disturbed. You can migrate. You don't need to be on that classroom. Right. If there's no other question, let me give 30 seconds. If there's no other question, I think we should call it a day so that everybody goes about their Saturday business. Wish you a good time, and I will see you on the program. Any questions? No. Okay, I'll see everybody on the program. Please do enjoy your weekend, and see you from tomorrow for people who are on tomorrow with us. Thank you.